Hi, this is Mark Finch. This is a short video to give you a simple and effective way to understand how to integrate fascial research into your clinical practice. So follow along for the next couple of minutes and hopefully it'll be something useful for you in your practice. So the basic idea is that there is this massive volume of fascial research that's come about in the last decade or so. In fact, as of about last week, there was about 16,000 PubMed articles with fascia in the name. There's so much research now that there are conferences just on fascia. In fact, we just had the last one here in Vancouver, BC. And these conferences are just on fascial research, and we're now into the third conference spaced every 3 years. The question really is, how do we take all of this research and make it relevant in the clinic in terms of what we're doing with our hands and the patient that's standing in front of us who's coming in with pain or dysfunction. So the way that I've started thinking about it, and lots of students have found it helpful, is to think about this thing called the 3S gearbox, or the triple S gearbox, and that would be strain, sensory, and sliding. So this 3S gearbox that I'm suggesting you consider gives you an idea of thinking about fascia in terms of strain, in terms of sliding, and in terms of its sensory input into the brain. So first off, strain, a few things that we know about fascia from the research. Fascia responds to load. This is really important when we're dealing with regular dense connective tissue, and lots of this data comes, or this information comes from the tendinosis research, from people like the fantastic work of Jill Cook. We know that to heal regular dense connective tissue, and especially tendons and ligaments, it needs to be loaded progressively and over time. Second thing that's interesting from Peter Hying's work is that strain is transferred perpendicular to the fibre direction. So that means that two muscles that are sitting next to each other, quite often via the regular dense connective tissue, there's going to be a transfer of strain between those two structures. And somewhere in the nature of about 30% of strain goes laterally from one structure to another structure. What this means in our practice is we need to consider structures that are adjacent to the first thing that we're really interested in treating. Fascia can be elastic in some situation and it creeps in other situations. So the amount of load and the timing is really important here. So for example, the Achilles tendon can behave in an elastic manner in runners, and the ligaments in the spine, for example, can creep slowly. So they slowly have this plastic deformation after about 45 minutes. So that gives us a different set of advice to give to our clients after we've treated them. And the last thing I've got here is that large muscles can be coupled into these slings, which forces us to have this global perspective. So Diane Lee, Andrea Vleeming, Tom Myers have all described these long and functional slings that give us this global overview of the myofascial system that's joined together via the fascia. So that's strain. The next part of the gearbox is sliding. So the gearbox analogy works such that sometimes the gearbox is transferring strain, as in a car it's driving the wheels forward, and sometimes the clutch is in the gearbox and there is sliding between two adjacent tissues. So the basic idea is that there are layers of loose connective tissue between structures that allow for sliding. So one muscle can slide on the aponeurosis underneath it, and it does that by having a thin layer of loose connective tissue between those two structures. It's possible that the sliding of tissues is really what we can feel as increased length. That we're not actually lengthening fascial tissues per se, but we're allowing them to slide more easily. Therefore, they're more adaptable, and therefore they feel like they can get longer. I think that sliding is a really important consideration in manual therapy techniques, and especially looking for those interfaces or areas of the myofascial system that should be sliding, that aren't sliding, can really help to very quickly make change in function and in strain patterns. So sliding and strain really go together, and sliding is often the piece that's missed by many clinicians. The other very important S is sensory. It's well proven now that fascia can be a pain generator, so there's nociceptors that have been found. I think in the thoracolumbar fascia primarily, but there are mechanosensory receptors all through the fascial system, primarily in the regular dense connective tissue, the tissue that transfers the strain, and the brain is constantly listening to the data or the sensory input that's coming from these tissues back to the brain. So what that means in terms of your practice is that it's very important to consider the proprioceptive element and to make sure that the client or the patient's brain is engaged in the treatment. The easiest way to do that is to make sure that they're moving. And to also give them homework that includes building their body awareness or their proprioception. So not missing the fact that the fascial system is heavily populated with mechanosensory receptors. So we've got 3 S's: strain, sliding, and sensory. And the question to ask yourself is, what's the function of the fascia that I'm treating? So if you ask yourself that question, I think you'll be able to make more sense of all of the fascial research that's out there, and most importantly, be able to affect a greater change for the clients that walk in your door. So I hope that little analogy is helpful for you, and if you want to find out more about it, then come to one of my courses.